I'd like to introduce our next speaker. He has spent more than 15 years in health IT, having designed, built, and managed web applications that have helped to improve the quality of patient care. He currently leads the strategy and cross-functional efforts on Salesforce's health products, establishes partner and consumer presence on the company's development platform, and enables health applications for nonprofit organizations through the Salesforce Foundation. It is my great pleasure to introduce Dr. Joshua Newman, Chief Medical Officer and Vice President of Health Strategy at Salesforce.
Today I'm going to talk about journeys and relationships as important components to taking care of people of all walks of life with all kinds of different medical conditions all around the world, although we'll be focused more on the US as I tell the stories today. And so thanks. So it all begins with a problem. And the problem here is represented by this map of Baltimore. And what you'll see in this map of Baltimore is that the dark red areas, and these correspond to counties, the dark red counties have a life expectancy of about 67, 68 years, and the legend is on the top. The dark blue counties have a life expectancy in the 80s, much closer to the sort of the average, or what we consider the average in industrialized countries. So the question really is, how come within a span of just a few miles, there's a life expectancy difference of 15 years. 15 years. That's 15 years of work that people aren't doing. That's 15 years of taxes that they're not paying. It's 15 years of grandchildren that they're not seeing. It's profound. And so the question is, so the answer is not in the difference in drugs. And Johns Hopkins is littered all throughout there, and a bunch of different clinics and all sorts of stuff. So the difference is not services or X-ray machines or procedures. There's great surgeons. There's great docs all over the place. What's the difference? And there are a lot of complex reasons why this is the case. But we can look at a lot of cities like this. We can look at a lot of conditions like this. And even within an area, we'd see disparities, differences in how people do. So the question is, why do some people do better and some people do more poorly with the same disease? And what are the kinds of things that we can do as a society, as a community, as technology, to try and bridge those gaps? And more maybe personally, how can we make this the case for ourselves, our loved ones, and the people we care for professionally and personally? So I was lucky. I was trained by a bunch of old-time physicians before the age of handheld anythings except paper and pen. And they were in turn trained by people from an even previous generation. So this is a story that I got from one of my professors in medical school. He trained in the 40s in Chicago, and he told this following story. Medicine today even teaches by rounds, and so what you do is you walk around the hospital and you treat patients. And the medical students tend to tell the story of what they've learned about a patient. They tell it to the eminent physician, and the eminent physician gives his opinions. And so the story went something like this. The medical student was presenting in front of a group of his colleagues and this eminent physician, and was talking about a woman who had come in for surgery, and was reporting on this patient's story. He said this woman had some upper quadrant pain following dinner, and got worse over time. And then the eminent physician said, stop, and turned right to the patient. And this is what he said. He said, I bet you had these feelings and you decided to ask some friends and family what you should do about it. And she said, yeah. And he said, I bet that they offered you this home remedy for it. And she said, yeah, but it had this side effect. And she'd say, yeah. And then he'd say, and I bet you love to read. She'd say, how do you know that? And he said, because I can see your glasses on the nightstand. And I can see that you're nearsighted. You're about a -3, right? And she'd say, yeah. And he'd say, and people who are nearsighted like the world to be close to them. They like to read, or they like to do things with their, small things in front of them, because that's in focus. And she was amazed, and everyone was amazed at his insight into how people were. Or he'd get to the end of it, and he'd say, I bet your family loves your baking. And someone would say, how do you know that? He'd say, because I see you've got burn marks on your arms from taking pan out of the oven. And I see that it's been there for a long time, so your family must love your baking if you keep doing it over and over again. It's that kind of insight. It's that kind of understanding of people's stories about who they are as people and why they're in the situation they're in that can sometimes be the most effective tool in keeping them healthy. Not just the medicines, not just the procedures, and not just the imaging studies. So here's another, I'll tell you 2 stories of this, both related to diabetes, and I think a lot of people hear about diabetes, and it's the cause celeb in healthcare. Everyone likes to tell stories about diabetes because it hits so many different important parts. So the first is a patient, a Mexican woman. Her name was Maria, and she came in, and she'd show up in my clinic, and she'd give me her little booklet. This is the days when you had to write down your AccuCheck numbers, or blood sugar numbers. And she'd show me the little booklet, and it showed what her blood sugar was based on the insulin we were giving her and her diet. And every once in a while, there were a couple mornings where her blood sugar would spike up in the 400s, sometimes the 500s. And I said to her, what's the story? You know about what you should eat, you know about what you shouldn't eat, you're taking insulin, you're taking orals. What happens? She says, well, sometimes I wake up in the middle of the night, and I'm really hungry, and so I make myself tamales and picadillo. Picadillo is the stuff on the right. It's ground beef and peppers and onions and cilantro and all kinds of good stuff on a big plate of rice. So you can imagine what happens when a diabetic eats a whole bunch of this food in the middle of the night and hasn't taken any extra insulin, and then she shows up in the morning and she's got spiking blood sugar levels. The common answer to this problem would be to give her more insulin. Why not? Just give her more insulin, right? But that's not really the cause. The problem was she had had a family trauma. She had been a customer service representative for Comcast. You can imagine the kind of stress she lived with that. And the process was really around getting her nutritional support and getting her therapy for her depression, which really was causing her to wake up in the middle of the night. And given the choice between being hungry and sad and delectable foods like this, I think it's an easy choice. Telling people not to eat what they love that makes them happy sometimes doesn't work. So we have to think about other things. Another story is also related to diabetes. I had another patient. I was working in urgent care, and the nurse who runs triage came up in the middle of my shift and said, sorry, I got to add someone to your shift. I said, okay. She said, but he's sort of tough. I said, really? She said, yeah, he's sort of hard of hearing, he's deaf, but we'll bring a sign language interpreter, which is always hard, but it's better than nothing. And he's got some prostate problems, but he's got diabetes, and he scored a blood sugar in about 600 range this morning, so we got to bring him in. It's sort of urgent. And he's also maybe a little bit there may be developmental issues, and maybe emotional issues, and she sort of scared me that this was going to be a really tough patient. And for any of you who are physicians out there, you know that when someone's added to your schedule who's tough, and you got to take the time, it can cause all kinds of havoc in your schedule for the rest of the day. And I had meetings in the afternoon. So he came in and I asked him what was going on, and it turned out he wasn't developmentally delayed. He didn't have cognitive issues. He didn't even have emotional issues, except for the fact that he was really angry. And what he was really angry was about that he wasn't getting good care. So I asked him, why did your blood sugar spike? Do you know about the medicines to take? He said, yeah. He said, but it's easier to pee. And so it's a sort of a silly image that sort of represents it. But the point is that when you have high blood sugar, when you have diabetes, one of the side effects is a condition that people call polyuria. It just means you have to pee a lot. What happens is your blood gets really concentrated. It sucks water from all your different tissues, and it ends up in your bladder, and then you have to urinate a lot. And he found that because of his prostate issues, it was more comfortable for him to have high blood sugar because that enabled him to actually urinate. That he couldn't do if he didn't have these sky-high rates of blood sugar. Again, the common answer to treating this patient is give him more insulin and lower his blood sugar, but he wasn't going to do that because he needed to urinate. So really the proper way of treating this person was making sure he had someone to talk to, and making sure he had a urology appointment that day so he could figure out what's happening with his prostate and get treated so that diabetes wouldn't cause trouble. Again, these are situations where it's not the thing in the middle of your face. It might not be the thing that someone's building an app for. It's about relationships, and it's about understanding that really cause this thing. But there's another component to this which is really important, which is payment. I've been hearing since I trained about how it's important to take care of people in this way. The old joke in family medicine is you can't take care of someone until you know their pet's name. And I had professors that would teach us to write names of people in the side margins and to take care of them that way, but there's one piece that wasn't there, and that was funding. There's not a lot of money in doing this kind of thing until now. So I'm really proud and happy and pleased, and we should all be encouraged that for the first time really ever in the history of our country or society in some ways, there's actual money for doing the right things, for taking care of people. It's not enough. It's not as much as we want. It's not going to totally solve all the problems, but it's heading in the right direction. So CMS just released some information a few weeks ago saying that they'd saved about $380 million on their Pioneer ACO, about 200,000 patients. There's tons of data that's coming in all over the place about how some of the new policies about value-based reimbursement and capitated payments and all kinds of things like that are causing organizations that had never really thought about this kind of thing to start thinking about keeping people healthy. That now there's a financial incentive for lowering the fee-for-service services that are happening. So there's money there. It can't be underestimated, and it can't be overstated, but it's important. But I'm not going to talk about that because I work for a technology company, and I'm going to tell you how we actually solve these problems. So I'm going to tell you 3 journey stories, but we're going to start going way back. We're going to start in the 1850s, the first example of health IT, which also happens to be, as many people say, the first example of epidemiology. Is anyone familiar with this map? Has anyone seen this map before? A lot of you probably have. It's a map of the cholera epidemic in London in 1854 made by John Snow. And what he has is a bunch of dots where actually people suffered cholera. This is a disease, a terrible disease. It's killed tens of thousands of people over the years around the 1850s, and before then they had outbreaks every couple of years in Europe, killing tons and tons of people. But what he found, and they didn't know what caused it. They thought it was miasma. If you actually look it up, they thought it was something in the air that just got people sick. And what they didn't know was that it was in the water. And so if you see, there's an area, let's see, right around, there's no laser pointer, but right in the middle there was a pump. There was a water pump, and someone had washed their baby's diapers in that pump, and the water there, and there was a broken pipe, and the pipe allowed some of the bacteria to get into the water supply, and a bunch of people got sick with cholera. And they noticed that in the brewery right nearby and in the prison nearby that had separate water supply systems, no one got sick. So John Snow successfully lobbied the city council to take the pump off the water. People didn't use water from that pump anymore, and cholera rates went down. Remarkable. He didn't know what caused the disease. He didn't know how to stop it. They had no antibiotics back then. But the intervention around technology, around understanding what people are doing and what's making them sick, saved countless lives. A really interesting epilogue to the story that I just learned in preparing this talk was that the city council members were so afraid of admitting the truth around fecal-oral contamination. It was such a freaky thing for them that they couldn't internalize, that they put the pump back on. And it took a while for them to take it back off again and to admit the fecal-oral route. So for those of you that sometimes lament that we don't have people who are fully versed in science, it goes back a long time. So from the map in the old times to a map now, all of us are familiar. This is Google Maps. This is Los Angeles. That red dot is a place on 5th Street east of downtown. This is a place where I did my fellowship, and we were working in the Skid Row community, trying to bring together the different providers of care for poor folks there, homeless people. And what I would do is I would start at this view, and then I'd go to the street view. So it's very similar to John Snow's map. Take John Snow, and this is just the modern version of John Snow. Except the problem is not water. The problem is something else. So the Google Street View car, as it drives through LA, can only do it early in the morning. And when they drive through this neighborhood early in the morning, what they see are tents, because there's so many homeless people in this neighborhood that they're actually living on the streets. So the project that we did here in LA gave rise to this project, which is called Care Harbor. And it's funny, I was showing this picture earlier to Jody, and Jody said, oh, is that Katrina? Like, what is that? And I said, really, it's not Katrina, it's LA, every day. This is a program that's been running in LA for the last 4 or 5 years, and it's called Care Harbor. It's had different names over the years. And what it is, it's a week-long event at LA Sports Arena. And they take care of about 800 people a day. They do thousands of teeth pulling. They give thousands of pairs of glasses. They do mammograms and physical exams and education and all kinds of things to connect people. And they do a lot of this on Salesforce, actually. So the first year they did this, we built them a system so they could register people and follow them through the stadium. And over the years, it's gotten more and more robust. They added fax capability so they could fax people paper. They put a little barcode on the side of it so it would get attached to their record. They've built mobile devices. They have people checking in using bracelets. You can see there a picture of the actual, I think that's the dentistry area. You can see everyone just getting group dentistry care all together in this thing. Now you might say, well, this is clinical intervention. What's the journey relationship part here? This is one day someone comes in, they get a bunch of care, and then they leave, right? Well, the fact is, it takes a lot of work to put on something like this. It takes a lot of work to care for a couple thousand people in a week in LA, and so there are bracelets. People wait in line. They get an armband, a wristband to say when they're going to enter into this system. They enter in the system. At each station, they get followed through the system. And these days, upon discharge, because the organization has gotten more sophisticated, they're actually sending referrals to different organizations and allowing them to get some of the information that was collected in this organization, in this event, to be sent to people in the community to get referrals and follow-up and specialty care and so on. So logistics really count. Here's a picture of what happens. So on the left, you'll see the mobile device. They built a mobile app to let volunteers and patients check in. And on the right is something that's a Salesforce dashboard, and it just shows what's been happening. So you'll see the histogram on the lower left shows the ages, and you see a pretty steep drop-off around when people get Medicare, because they're getting care. On the lower left, you see that pie graph shows people's ethnicity, and the yellow is people of Latino origin. And in the lower right, you see a pie graph about how long people have been waiting. And those big pie slices, the orange, the pink, and the yellow one, and the colors are almost the same on that side, represent 3, 4, and 5 hour times that it takes people to get care. So people are getting care, and they're getting pretty good care, actually. These are all mostly UCSF and pretty well-trained, excellent doctors. But even then, it takes a long time. So the logistics of a journey, the logistics of getting care and actually getting into a position where you can get help is really hard, and it's important. It needs our attention. Another story, mammograms and breast cancer. It's a really important issue, obviously. And the challenge is, what do we do? Some people believe that every woman over 40 should get a mammogram. Some organizations believe that everyone over 50 should get a mammogram. And how do you figure that out? Well, Laura Esserman over at UCSF has been doing some tremendous work. Also, it happens to be on our platform. And what she does is when a woman gets a mammogram, she sends them a survey. The survey has family history and past medical history, and it makes the mammogram more accurate. That survey, the results of the survey go to a decision support tool that then give the woman a risk score. And based on that risk score and a consultation, they can make a decision on what to do. The reality is some women need screening at 40, and some women need it at 50, and some women probably need it even earlier. And so she's taking this system, which has been successful, and she just won a fantastic $14 million grant, and she's going to be adding genetics, and she's going to be adding payment to this whole process, which has the possibility of really changing things around. And you can see here, that's Laura on the left, and you'll see the different steps in the training on the bottom, the steps in the clinical care and the screening process on the bottom. The reason I showed you this website, and you can go here right now if you want to, the reason I'm showing you the website is because this is not only clinical care, it's research. And if you would have shown someone a picture of this 10 years ago or 20 years ago and saying, yeah, this is the future of research, it looks like a company, or it looks like a startup or something like that. In a lot of cases it is. But the way that they're reaching out to people and the way they're communicating to people and the kinds of value they're giving to folks not only evokes this kind of, this idea of a journey, but evokes the idea of being a consumer and being more in charge of your life and your health. And she's been really successful at it, and I encourage all of you to learn more about it because it's a tremendous program. The last story I'll tell you about has to do with really sick people. So most of you probably know this, but the top 1% of the population is responsible for roughly 20% of the cost of medical care. And the top 5% take care of about 50% of the cost of medical care, which tells us that there are some people that are very, very sick, and caring for them is very, very expensive. And those people need a lot of effort and a lot of energy and a lot of time. But in general, we haven't been segmenting the population like that. We've been giving everyone everything for a long time. Now, those people tend to be poorer, they tend to be sicker, they tend to have fewer resources of their own, they tend to be less educated, and we know all the reasons. We don't know all the reasons, but we have ideas about how education relates to healthcare and health outcomes. And so the question is, what do we do with these people? Well, it turns out Johns Hopkins cares. They've got a health plan that's connected to their organization that's responsible for about 500,000 people. And in those 500,000 people, there's obviously a cohort that's really sick and really poor. And to bring it all back, to tie this all together, a lot of them live in those neighborhoods in Baltimore that I showed you early on. And a lot of them are former workers or on the insurance plans of former workers, of people that are actually being cared for by Johns Hopkins healthcare system. So Johns Hopkins wrote a grant, a $10 million grant to CMS, and they won it. It was great. And actually, it was a $19 million grant. And they also built a system, a simple system. The technology that I'm telling you about is not complex technology. They built a system to survey these people and find out what the problems were. Now, some of them didn't have technology themselves. They didn't have a laptop at home. They didn't have a smartphone that they could use anytime they wanted to fill out this survey. So they actually found it was cost-effective to get medical assistants or some lower-level people in the healthcare profession that were part of the Hopkins community to show up at these people's houses with an iPad and have them fill out the survey right there, just to figure out what it was. And what they found was the gaps were not insulin or antihypertensives or I can't get enough x-rays, that's why I'm sick. No one said that. They said I can't eat, I don't have food, I don't have rent, I don't have transportation, I don't have someone to take care of my kids, so I can't go to the hospital. All kinds of things like that, or my grandson, things like that. So they surfaced those problems, and they found ways to bridge those gaps using the community. Community resources, community help, folks like some of you, or any of us who volunteer. And they were using, again, they used Salesforce to do this. So in each one of these cases, technology, in the case ARC technology, because I'm a little more familiar with it, our technology has been used to manage a journey, to manage a relationship, and to take care of someone regardless of where they are, temporally or from a health standpoint. And so I guess the point that I really want to leave you with is that these relationships and these journeys are becoming more and more important everywhere. Obviously, some of these examples are from underserved communities, but we're seeing it in all kinds of communities. We're seeing concierge medicine sort of filter down to all kinds of folks. There was a time when you needed thousands of dollars a year, and now you only need $100 a year to be a part of One Medical. And there are even organizations that do it for free because they feel like it's important to them and it's important to the community for any reasons that you can think of. And there are altruistic reasons, there are economic reasons to do the right thing for these kinds of folks. So I hope you all have a great conference and you learn a lot. And I hope you continue the great work you've been doing, and thanks again for listening. And if we have time, I think do you have time for a few questions? Great. So if anyone has any questions, I'm happy to answer any questions that you guys have.
Hi, John Templeton. Working on something similar to the Johns Hopkins model in West Contra Costa County. What have been the outcomes in terms of outcomes for clinical,
I don't have really solid data, and I would have to work to get you those numbers, and I don't know if they've done it too, but what I've heard is they've had lower ER admissions in that population. They actually try and head people off in that way, and they've had some lowered costs. But obviously they had to make some investment in this, so I don't know the exact numbers. The most solid number that I've heard is lowered ER admissions. What was the question? I'm sorry, the question was, the gentleman is working in a similar project in Contra Costa County and asked if there were any outcomes to report from it. And they're mostly anecdotal at this point.
You heard about this single physician in Camden who's dramatically reduced the cost of healthcare of like $4 million in the Camden market? And, right, and he just went around and he was a family practice doc. The reason I brought it up is that I want to emphasize it wasn't a technology, he just went around and figured out who the most common people that would show up at the ER, the frequent flyers, and then go to their homes and, in Camden, which you can imagine even makes Baltimore look safe. And he would go to their houses and he would essentially figure out why this diabetic who had just gotten a toe removed because he wasn't in control, and he'd see the house he was in and realize it was a crack house and he wasn't. So this is one of the things that I find, and I just wanted your thoughts on, do you think the emphasis on mobile and digital misses some of the social economic factors that maybe there's some way to balance that, or maybe technology needs to become more human? I don't know, what are your thoughts on the social economic implications of improving medicine within the context of, say, a technology forum conference like this?
I'd love to hear someone to say, no, technology doesn't need to be more human. I'd love to hear someone say that. It's a really great point. Two other examples, by the way, from this doc in Camden. One is a company called Iora Health, run by a guy named Rushika Fernandopoul. If any of you have been to any other conference ever, anywhere, he's on the circuit. It's a great story, Iora Health. They do this sort of institutionally, and they're growing. They're great. Another one is if anyone has a really good arm and a baseball, you could probably throw it to a tremendous innovator in this area, a guy named Alan Glazeroff over at Stanford, primary care doc who's really concerned about this kind of thing. And what he did was he found that he would go in and say, okay, here are the priorities. Lower your blood sugar, lower your hypertension rate, exercise, do all this stuff. And they said, whoa, like I'm freaked out because of my job and my kids and all this other stuff. And he realized he wasn't going to make any headway until he addressed people's needs themselves and where they were. So they started dealing with things that had nothing to do with medicine. And they found that once they figured those things out, people were much more amenable to fixing this. So those are the models. Those are the stories that I'm hearing about where people are successful. I think when it comes to technology, one of the in the blurb that I sent to Prannoy about what I was going to talk about today, there was a little bit of a dig against high tech and super like far out things. And we can focus on those things. And obviously genetic screening is important. Obviously the kinds of apps that people have can really help them. Maybe even those things that people wear on their wrist can really help them. But I think that before you want to send a super advanced AI algorithm to ask someone how they're feeling and do some decision support and give them something because of it, it's really easy to pick up the phone and say, how do you feel? What's wrong? What's bothering you? And we don't need any technological innovation for that. So the stuff that I really get excited about are the relationships. Obviously, it's not scalable. So I think there's going to be a time, over time, we're going to find that those kinds of human relationships some of it can be delivered or making much cheaper with technology, and that's.
Do you know that in San Francisco, are you aware of any platforms that connect all the different programs, or rich programs for all underserved in the city? But do the caregivers and the different clinicians have ways to refer people? Is there an easy way to do that?
I'm not aware of it. There are small networks that have that. And there are networks of, and probably some of you know this better than I do, there's networks of services for underserved communities and so on, but we're still not at a point where there's like a fluid marketplace of this kind of stuff and in healthcare in general, and we hope to see it.
Linkages here in the Valley, I don't know if it's up in San Francisco, that is basically people volunteer their time to each other to help in social economic issues.
Great. In the back and then right next to you.
France has a model, maybe someone from Europe can elaborate on that, where the caregivers who come to the homes have dual or triple functions, where they take care of the patient and also do other cleaning and things like that. And if they notice that the patient is not showing movement or needs to be admitted, they kind of give first-hand information to the doctor and then they do a follow-up. So it's not on demand, but you constantly have contact with the patient.
I think as we see results and outcomes, we're going to be able to lobby for that, and people will be willing to pay for those kinds of things.
So, we've all heard stories of these Columbo-like, sussing third-order effects out, and particularly when we see doctor shows where the, eminent physician uncovers these things. Has there ever been any actual formalization of expanding the purview of medical students to look at the ethnography and look at these lateral effects that cause the problem?
When I trained, they emphasized that a lot. And I went to the University of Illinois at Chicago as a medical school. It was a state school, and so there's obviously a real interest in getting people to take care of the bulk of the population, which are not people that live, around here. So there is a lot of appreciation for those kinds of things and attempt to teach it. I think it's probably happening more and more, and I think actually the most interesting aspect of your question to me is how medical school and training needs to change. And to ask that question is to sort of understand and realize that we're sort of like 18th century professional people, like trying to live in this world. We're trained in a time when it was just us, just our brains, whatever we can remember, and we can do whatever we want with the people. It came from a time when we were sort of by ourselves and taking care of folks. We had no technology. And I think what we're going to see is a lot of things changing. So the prominence of a physician, hopefully, is going to go down. And the prominence of medical assistants, and I like to talk about 23-year-old Facebook ninjas who can make Mrs. Johnson feel more love in a text message than a doc can in an 8-minute visit. I think we're going to see more and more of that as we start seeing the results, as we start seeing the outcomes, the costs, and the benefits of, again, relationships and helping people on a healthy journey.
Part of the reason I ask that question is because technology is, like most things, a double-edged sword. So even though you can improve certain aspects of it, there are unintended consequences. So there was a discussion that a gentleman who runs hospitals at UCSF wrote a book about digital technology and what's wrong with it. And one of the problems was the old days, you went down to the basement to talk to the radiologist, and you'd get lots of wisdom from that. And then once everything was digitized, there was no reason to go down there, and everybody lost out on those lessons. And so there are lots of pockets of those examples. And So there needs to be some counterbalance to the not doing things just because we can, because they're valuable, but also looking at the counterexample of what's likely to go wrong.
Yeah, I always think the protection against that risk is talking to old guys and old gals, talking to old people who train at a different time and who are thinking about some things and seeing the changes and guarding against them. It's a really important point. It goes to the other gentleman's point about, do we really need to give everyone a smartphone and a wristwatch in order to keep them healthy? And hopefully no. If there's no other questions, we'll end. Thank you all for your attention, and good luck with the rest of the conference.